Welcome to Team-Based Learning. It's Friday, and we're expecting the residents here in a few minutes for a team-based learning session on the topic of hyperthyroidism. This video is meant to allow faculty to see how a TBL is presented. TBL is a teaching method which presents a topic by doing away with the traditional lecture and substituting it with a required reading assignment. TBL takes learning further by then asking the residents to apply their knowledge through solving cases and solving problems after discussing them in a team setting. The faculty serves as a facilitator instead of as a lecturer and makes teaching points on each of the cases or problems as they're presented. We're in room J305 and at the medical school, and this is a good space to have a team-based learning session because there are tables for each one of the 8 groups, and there are monitors where the facilitator can project questions, cases, and teaching points as the team-based learning proceeds. I'll just review the basic components of team-based learning, and there are 4 of them. Self-study, the Individual Readiness Assurance Test, or IRAT, the Group Readiness Assurance Test, or GRAT, and finally the application exercises. So firstly, self-study. This is in the form of a required pre-reading, which is usually a book chapter or a review article on a topic that goes out to the residents about a week ahead of time. The residents acquire the knowledge through reading and self-study. The actual TBL session starts with the second component, which is the Individual Readiness Assurance Test, or IRAT. This is a series of 5 fairly basic knowledge-based questions that, for the most part, come directly out of the reading. The residents answer them individually, and then the IRATs are collected. The second component is the GRAT, or Group Readiness Assurance Test. Here, the residents, in their teams now, discuss the same 5 questions as on the individual test, and they come up with their single best consensus answer. They answer using a scratch card and scratch off their answer to all 5 questions. In this way, they get immediate feedback for the 5 questions, and that's one of the reasons this special scratch card is prepared for team-based learning exercises like this, and is called an immediate feedback assessment technique card. The facilitator then reviews the 5 questions and presents a teaching point slide for each one of them, and reviews the clinical pearls that go along with each of the questions. The last part of a team-based learning is the application exercises. Here, the facilitator presents 5 clinical vignette cases. These are board-style questions, and we are currently using questions from the Medical Knowledge Self-Assessment Program, or MICSAP. The facilitator presents each case, and the teams discuss for about 5 minutes, and then they give their single best consensus answer, this time using an audience response system clicker. The facilitator can then show their responses on the screen, reveal the correct answers, and review a teaching point slide to review the clinical pearls. Now we're over at the podium in room J305, and I'd just like to show you some of the technical aids and supports for team-based learning. We have a technical support person who helps set everything up for the facilitator. The PowerPoint, including the interactive audience response system slides, is brought up on the room computer and projected on the monitors around the room. The Turning Point audience response system we received from the Schaefer Library, and our assistant helps to set up the audience response system and place the ARS clickers on the tables. The individual readiness assurance tests and the immediate feedback assessment technique scratch cards are placed on the tables. And finally, there's a portable microphone available for the facilitator. In other words, the entire room is set up and the facilitator just has to arrive at 11:45 and get oriented and then begin the team-based learning at noon. In just a few minutes, the residents will arrive and we'll get started and see how it's done. Okay, so welcome to Team-Based Learning Friday Noon Conference. Today's topic is hyperthyroidism, and I am not an endocrinologist, but I think I can teach you something about hyperthyroidism today. If some questions come up, we have Dr. Desimone here also, who's an endocrinologist who can help clarify concepts. So at this point, I'd like to point out that those yellow sheets on your tables are normal lab values, in case you need to refer to those while we're doing this exercise. And please leave those on the tables when we're done, because we're going to collect them and reuse them next week. So why don't you go ahead and turn over your readiness assurance tests and just do those 5 questions individually, and then we'll collect those in a few minutes. All right, everyone, has anyone else got an individual readiness assurance test out there? Have I got them all? All right, thanks for doing those. So at this point, we're going to move on to the group readiness assurance test. So now in your groups, you're going to discuss the same 5 questions on the readiness assurance test and come up with your single best group consensus answer. And then in your groups, you'll find your IFAT scratch card, and you can scratch off the correct answer and get immediate feedback on that. So why don't you go ahead with the group readiness assurance test and go ahead and discuss those 5 questions.
71-year-old male, history of hypertension, failure,
I think this is non.
all this stuff is poison.
Or not. It was not scenario.
So, cardiovert, okay, yay, diabetes, okay. Then this is the other one, LEM is low, 35%,
Not just had an MI.
Yes.
So the preferred treatment of hyperthyroidism caused by multinodular goiter or toxic thyroid adenoma is methimazole, PTU, thyroidectomy, radioactive iodine, I-131, or thyroidectomy or I-131. So let's see. Team number 5. What was the correct answer on this one? E. Okay, thyroidectomy or I-131. Okay, good. That is the right answer. So would anyone like to make a comment about treating someone with a thyroidectomy who has these conditions? When would that be desirable?
Pregnancy.
Pregnancy? Okay, don't want to give radioactive iodine to someone who's pregnant. Who else would be a candidate for thyroidectomy if they had multinodular goiter or toxic thyroid adenoma? If they failed I-131, for example? Okay, good.
Or the thyroid nodules are thought to be cancerous, suspicion for cancer.
Suspicion for cancer, yeah, you probably want to do surgery then. That's a good point. Anything else? Toxic or multinodular goiter, what can happen to your neck? You can get a mass effect there from the multinodular goiter. So if it's bulky or if it's uncomfortable, then oftentimes surgery is the right option. For most other cases, thyroid or I-131 radioactive iodine does treat those 2 conditions. How about antithyroid drugs? Those were some of the other answers there. So why would antithyroid drugs not be the right choice?
Not as effective in those two cases.
Okay, not as effective? How long would you have to treat for if you used them? Probably forever. Yeah, unlike Graves' disease, toxic adenoma and multinodular goiter do not go into remission with antithyroid drugs. So here's the objective: treat hyperthyroidism due to multinodular goiter or toxic adenoma. I-131 effectively treats these two conditions. You know, about 50 to 75% of patients will develop hypothyroidism as a result of the therapy. That's okay. They can be put on levothyroxine hormone replacement. It's not uncommon and not necessarily, you know, the end of the world. Thyroidectomy is an option, particularly those with bulky nodules or mass effect. And then you can see their antithyroid drugs work, but don't result in permanent remission. And for long-term treatment, I mean, you could use them as a second-line option in patients who just refuse to get I-131 or thyroidectomy. So we're going to go on to the application exercises. So we're in the interest of time in getting you guys out of here by 1:30. Go ahead and discuss each one, and then as soon as your group has their answer, you know, you can answer using the audience response, and I'll be able to track here to see, you know, if all 8 groups have answered, and we'll try to move through these fairly quickly.
That's true. She's just a signal. She actually knows my patients well enough that it's fine. That's right. That's fine. That's right. She actually knows that she knows patients that have been there forever, and one of them has a discharge summary, and nothing's been done since the discharge summary.
Yeah.
The goal is still there.
Okay, so we're going to finish up this question here. All right, we have 6 responses. We're just looking for the 7th one. Did all the groups answer? All right, so is this person sick?
Yeah.
This person is very sick, okay? He is ill. Fever. He has abnormal vitals. He's got an abnormal heart exam, lung exam. He's confused. So, all right, thyroid storm, 100%. Okay, outstanding. So this is thyroid storm, and there's some things you should know about it. I mean, you can have thyroid toxicosis, and you can be hyperthyroid. But what makes it thyroid storm? There's certain clinical characteristics, and here they are: fever. You know, and in combination, fever, tachycardia, congestive heart failure, you know, from the tachycardia and overload. Abdominal discomfort is very characteristic of it, diarrhea, nausea, vomiting, and sometimes jaundice. So when you see this constellation of signs and symptoms, think thyroid storm. So the free T4 and the total T3 are often very elevated, sometimes more than they would be in just regular thyroid toxicosis. You often see it in untreated hyperthyroidism or in someone who is non-compliant with therapy. Sometimes there's a precipitant. In this question, there was something that precipitated the thyroid storm because he's on treatment for Graves' disease with methimazole. So what do you think precipitated the thyroid storm in this patient? What? With CT scan with iodinated contrast. The iodine in the contrast material can precipitate thyroid storm. Other things such as surgery and trauma. The treatment, you give antithyroid drugs, like PTU is preferred because it also blocks the conversion of T4 to T3. So oftentimes we treat with PTU. You give iodine solution, and usually intravenously, I think. High-dose steroids. Steroids can also block the conversion of T4 to T3. You give beta blockers to slow the heart rate down and to address the hyperandronergic state. Sometimes lithium is used. Mortality rate for thyroidstroma is 15 to 20%. I hope you got a sense of how the residents came prepared by having read the required review paper on hyperthyroidism. And I hope you got a sense of the interactive nature of TBL as the residents applied their knowledge through discussion and problem solving.